Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
This program is presented by Medscape Education Global.
Hello, I'm Vivek Subbiah, Chief of Early Phase Drug Development at the Sarah Cannon Research Institute in Nashville, Tennessee, in USA. Welcome to this program titled Unlocking the Power of Tumor-Agnostic Therapy, a Path to Personalized Cancer Care. Joining me today are Dr. Apostolia Simbiridu, Professor in the Department of Investigational Cancer Therapeutics and a Catherine Russell Dixie Distinguished Endowed Professor at the University of Texas MD Anderson Cancer Center in Texas, USA, and Dr. Fernando Lopez-Rios, Chief of Molecular Diagnostic Service in the Department of Pathology at the Hospital Universitario 12 de Octubre in Madrid, Spain. Welcome. In this activity, we are going to review tumor-agnostic drugs, what they are, those that are currently approved, and the clinical data leading to these approvals. We will then discuss how to use tumor-agnostic drugs in clinical practice and the role of precision oncology in the future. What are tumor-agnostic drugs? A tumor-agnostic therapy uses the same drug to treat all types of cancer that harbor the genetic mutation or the change or biomarker that is targeted by the drug, regardless of the cancer type or regardless of where the cancer was located in the body or where the cancer started in the body. Part of precision oncology, or we call the mantra of precision oncology, is finding the right drug for the right patient at the right time. So let's talk to our faculty now. What is the rationale for developing these type of drugs and how do they differ from traditional cancer therapies? So let me ask Dr. Leah Simbiridu this question. Thank you so much, Dr. Simbiridu. It's great to have you here.
Thank you, Dr. Subbiah. The rationale for developing these types of drugs is based on the increase of molecular understanding of the mechanisms of carcinogenesis and a deeper understanding of the cancer genome. The improved genome sequencing technology that has been associated with reduced costs have increased the investigational treatments that have been developed using this technology and understanding the tumor molecular profiling in individual patients. So this treatment is based on the molecular characteristics of the patient, of each patient, rather than the histology alone. It is based on targeting biomarkers, and it is individualized treatment for the patient and their specific cancer.
Thank you so much. So, Dr. Lopez-Rios, what are your thoughts on this question? What is the rationale of developing these type of drugs, and how do they differ from traditional cancer therapies?
Well, I think this is excellent news for everyone, for patients, for clinicians, for everyone in the lab. It's a huge change of paradigm, and I wanted to highlight that I think it's helping us transition to comprehensive genomic profiling, because until these tumor-agnostic drugs arrived, we had some tumors in which the number of biomarkers was high enough to actually make the case for next-generation sequencing, but it was very difficult to convince everybody that it makes sense from a clinical perspective, a cost perspective, a workflow perspective, to try to include as many patients as possible from other indications. So these new tumor-agnostic indications are making exactly that. So I think it's fantastic news.
Thank you so much, and very nicely said. So, how do investigational therapies, right? How do trials investigating tumor agnostic drugs differ from standard trials? So, let's talk about this for a couple of minutes. So, traditional clinical trial treatment strategies have been approved based on average population benefit decisions derived from randomized clinical trials of unselected patients, not suitable for tumor agnostic drugs. So, what has really brought the tumor agnostic therapies are advances in what we call as so-called precision oncology clinical trials, classified as basket studies, umbrella trials, platform studies. Again, these are novel designs that investigate multiple hypotheses through concurrent substudies, example, multiple treatments or populations, or that allow adding or removing arms during the trial. Let's talk about umbrella studies. So, what are umbrella studies? Umbrella studies are study designs that evaluate multiple targeted therapies for the same disease entity stratified by molecular alteration. Examples include the I-SPY, a breast cancer study, or the lung map, the lung cancer master protocol. Right? These are umbrella studies. The next one you can see here is a basket or bucket trial. Basket trials are tissue agnostic or histology independent studies where targeted therapy is evaluated on multiple disease types that all harbor the same underlying molecular alteration. For instance, the VE basket study, the VE denotes vemurafenib. The vemurafenib basket study was one of the first histology independent studies to be designed. And the next study is the rare oncology agnostic research, the ROAR study that led to the approval of dabrafenib and trametinib, and more recently, trials of tissue agnostic studies of RET inhibitors, the ARROW study of pralsetinib and the libretto study of selpercatinib. And these have led to several drug approvals in specific biomarker driven populations in a histology dependent and histology independent manner. What we see are the platform studies. So these are multi-arm, multi-stage study designs that compare several interventional groups with a common control group in the context of the same master protocol. So these platform studies can be perpetual immortal study designs with no defined end date and are more efficient, in my opinion, than traditional trials on account of shared control arm, which ensures that a greater proportion of patients are enrolled in interventional experimental arms than the control arm. Finally, we have something called the MOD study. The Master Observational Trial is a prospective observational study design that broadly accepts patients independent of biomarker signature. And I would go one step further, stating that in the future, we are going to be seeing more and more of these master observational studies, as in the real world data and real world evidence studies. So let's talk about currently approved tumor agnostic drugs. So let's turn on to our esteemed faculty. Let me ask Dr. Simbiridu first. Could you please list the tumor agnostic drugs that are approved by the US FDA?
Yeah, so we have the so-called NTRK targeted agents, both larotrectinib and entrectinib. We have the immunotherapeutic agents, pembrolizumab for MSI-high tumors and dostarlimab, also for MSI-high tumors. We have the combination of dabrafenib and trametinib, the BRAF and MEK inhibitors, respectively, for patients with BRAF V600E mutation. And we also more recently had the approval of selpercatinib for patients with RET fusions.
Thank you so much, Dr. Elias Simbiridu. Let's turn to Dr. Lopez Rios. Again, we can talk to him about the European perspective. Are there any differences between the FDA approvals and the EMA in terms of approvals for these drugs?
Well, the main difference is that dostarlimab is not yet approved by the EMEA as a tumor-agnostic drug. So we have access to larotrectinib and entrectinib for NTRK positive patients, pembrolizumab for MSI-high, dabrafenib and trametinib for BRAF mutations, and recently selpercatinib for RET alterations.
So let me turn on to Dr. Lopez Rios since I have you on the camera. So, could you please give us some more details on the clinical trials that led to some of these approvals? Perhaps you can start with the drugs targeting NTRK fusions, larotrectinib, and entrectinib.
So first, I will start with larotrectinib. It was approved by the FDA in 2018 and by the EMEA in 2019. So the identification of these fusions, as we all know, can be challenging. So the trials involved both adults and children. So there were phase 1 studies, phase 1/2 studies, and a final phase 2 study involving adolescents and adults. And the primary endpoint was the overall response rate. Entrectinib was approved also in 2019 by the FDA, but by the EMEA a year later in 2020. And here we had 3 phase 1 or 2 clinical trials, which enroll patients aged 18 years or older with metastatic or locally advanced NTRK fusion positive solid tumors. And in this case, we're looking at objective response and the median duration of response. I think when we looked at the waterfall plots from the larotrectinib studies, overall response rates, as you can see there, was well over 70%, 75% across many different histologies, and that's why we're talking of a tumor-agnostic indication and approval, and very similar data for entrectinib, as you can see there. So I wanted also to emphasize that when looking for NTRK fusions, given this tumor-agnostic perspective, we have to consider that some fusions are very prevalent in specific tumor types. So that's why I wanted to send out a very optimistic message. For example, it's relatively easy to find NTRK fusions in thyroid carcinomas, in some gliomas, in specific subtypes of colorectal carcinomas, of course, some sarcoma subtypes. So very important to keep this in mind to make sure that we don't miss any of these patients.
Thank you so much for the overview. So let's turn on to Dr. Leah Sembrido. So Dr. Sembrido, would you be able to give us some details on the key trials for approvals of pembrolizumab and dostarlimab?
Sure. The pembrolizumab was approved by the Food and Drug Administration in the United States in 2017 and by the European Medical Agency in 2022 for tumor-agnostic MSI-high tumors across tumor types. So the key studies that led to this approval include the following trials: Keynote 158, the Keynote 164, and the Keynote 051 trials. I will start from the Keynote 158 trial. So patients eligible for this trial had histologically and cytologically confirmed MSI-high or dMMR advanced non-colorectal cancer, and they had failed prior therapy. The primary endpoint of the study was the overall response rate according to the RECIST version 1.1 criteria. The second trial was the Keynote 164, and that was a phase 2 open label study that investigated the anti-tumor activity of pembrolizumab in previously treated metastatic MSI-high or mismatch repair deficient colorectal cancer. Also, the primary endpoint was overall response rate by RECIST criteria. The last study that led to this approval was the Keynote 051 study. That was a phase 1/2 open label trial that involved children from 6 months old until 17 years of age, and the patients had melanoma or a centrally confirmed PD-L1 positive relapsed refractory solid tumor or lymphoma. The primary endpoints of the study were to determine the dose-limiting toxicities at the maximum administered dose, safety, and the proportion of patients with objective response to pembrolizumab for each individual tumor type. I will summarize the results of the phase 2 Keynote 158, which was to look at the pembrolizumab in MSI-high or MMR deficient cancers. The overall response rate was 30.8%, and the waterfall plot shown here also shows a significant number of patients who had a clinical benefit from this treatment. We are familiar with the adverse events that are associated with these drugs, mainly inflammatory response of various organs and hypothyroidism. The second trial that led to this approval, the Keynote 164, was associated with an overall objective response rate of 33%, and the adverse events were similar. The third trial, Keynote 051, pembrolizumab in pediatric melanoma or PD-L1 positive solid tumors or lymphoma, shown here, was also associated in a significant overall response rate, and many patients had overall stable disease. This was across tumor types. And I will next focus on the Garnet study. This study investigated the role of dorsalimab in advanced recurrent MSI-high or MMR deficient cancer. In this study, the CR rate among 347 patients was 13.3%, and the PR rate was 30.8%, for an overall response rate of 44.1%. And many of these responses were long-lasting, and they were associated with prolonged overall survival, and the overall survival has not been reached in many tumor types. So this also was associated with adverse events that, as expected, for the use of immunotherapy, and led to the FDA approval of the drug, which is not yet approved in Europe.
Wow, thank you so much for summarizing the data that led to the approval of these drugs. So again, now it's my turn. So again, let me talk about the key trials for the approvals for the latest kids on the block, dabrafenib and trametinib, the first combination therapy to be approved in a tissue-agnostic space. Dabrafenib is a BRAF V600E inhibitor, and trametinib is a MEK inhibitor. This was approved by the US FDA in 2022 and approved by EMA for BRAF V600 mutation positive melanoma in 2015, and BRAF V600 positive advanced or metastatic non-small cell lung cancer in 2017 by the EMA. So let's talk about the key studies that led to the tissue agnostic approval of dabrafenib and trametinib in the US by the FDA. It was a pooled analysis of 3 studies. One is the ROAR basket study, the rare oncology agnostic research. And the second one is an NCI match study. And the third one is a pediatric study that also contributed to the approval. So the ROAR study is a phase 2 basket study of dabrafenib and trametinib in 8 cohorts of rare tumors harboring BRAF V600 alteration. At the same time, we had data from the NCI match arm H, again with the same drugs, dabrafenib and trametinib. Patients with melanoma, thyroid, and colorectal cancers was excluded. Patients with non-small cell lung cancer were later excluded in an amendment. And again, the trial also included 36 patients from a pediatric trial as well. As you can see here, this is one of the arms, or 2 of the arms of the ROAR basket study, showing data from the biliary tract cancer cohort showing a response rate of over 51%, and also another arm of the high-grade and low-grade glioma arms showing response rate of over 33% in high-grade glioma and over 60% in low-grade gliomas. Again, talking about difficult to treat cancers, this is one of the arms of the ROAR basket study, the anaplastic thyroid cancer. Anaplastic thyroid cancer is one of the most lethal cancers known to us. And this waterfall plot shows the response rate in anaplastic thyroid cancer. Again, deep responses, prolonged responses in anaplastic thyroid cancer. The ROAR basket study also had arms for hairy cell leukemia. And, interestingly, the investigator assessed objective response rate was over 89% in this cohort. A recent publication in Nature Medicine showcased the phase 2 data of all the arms of the ROAR basket study, showing that BRAF V600E is a validated tissue agnostic target, and dabrafenib and trametinib are validated tissue agnostic drugs. So this is the study from NCI Match, right? NCI Match Arm H enrolled, as I said, patients with multiple solid tumors harboring BRAF V600E cancers, with the exception of melanoma, thyroid, and colorectal, and later excluded patients with non-small cell lung cancer. Again, clearly you see that we see responses in a tissue agnostic manner across multiple tumor types. Again, we see side effects, right? We see adverse events across the board with dabrafenib and trametinib, and no unexpected side effects beyond what we see in melanoma in the tumor agnostic cohorts as well. And as you can see here, the latest kid on the block, selpercatinib in RET altered thyroid cancers. Selpercatinib was approved by the US FDA in 2022, and it's been approved by the EMA in 2022 for non-small cell lung cancer and thyroid cancer in disease-specific indications. So the key study led to the FDA approval in a tissue agnostic space was the data from the Libretto 001. This was a phase 1-2 single group open label basket study of selpercatinib in patients 18 years or older or 12 years of older were permitted by regulatory authorities with RET altered cancers. Again, the primary endpoint was objective response rate as determined by independent review committee. This is the data based on the Libretto 001 study. Again, you can see the waterfall plots here showing RET mutant patients with medullary thyroid cancer previously treated with vandatinib, cabozantinib, or both. RET mutant MTC patients who are treatment naive, not treated with vandatinib or cabozantinib, or both. And the final cohort showing the objective response rate in RET fusion positive thyroid cancer that include the papillary thyroid cancer, polydifferentiated thyroid cancer, anaplastic thyroid cancer, and Hürthle cell thyroid cancer, showing an objective response rate of over 79%. This shows selpercatinib in RET fusion positive non-small cell lung cancer from the Libretto 001 study that led to the accelerated approval in the US, and also the definitive final approval in the US by the US FDA. In the treatment naive cohort, the objective response rate was 84%, and in the pre-treated cohort, in patients who've seen platinum-based chemotherapy, the objective response rate was 61%. So again, we are still scratching the tip of the iceberg for tumor agnostic therapies. And I see a future where more and more drugs are going to be approved in the tissue agnostic space. Again, of course, the major form of drug development is going to be in a histology specific manner, but the tissue agnostic therapies provide access to patients with rare cancers and common cancers harboring specific alterations to therapies. Let's review some of the pan-tumor therapies showing future in the promise. Again, this is not exhaustive. Again, we are seeing more and more of these tissue agnostic targets. TROP2 ADC with saxitumab govitecan, again, is investigating in a basket study in a tissue agnostic space. Again, tucatinib and trastuzumab is also looking into HER2. And recently, the Destiny Pan-Tumor 02 trial was published. Again, this clearly shows that HER2 positive cancers, especially the HER2 2+ and 3+, are tissue agnostic targets with this drug called trastuzumab deruxtecan. And we are hopeful that this is going to be helpful in patients in the real world in the near future. So let's talk about how to use tumor agnostic therapies in clinical practice. We saw all the data that led to the approval, but let's talk about the real world. So how do we use these tumor agnostic therapies in clinical practice? Let's take a moment to listen to a patient describe their experiences with receiving tumor agnostic therapies.
I was diagnosed with stage 4 thyroid cancer November of 2010. The treatments I had for this diagnosis has been, I had a full thyroidectomy. I went through 6 rounds of iodine radiation. I also had a full radical neck dissection along with a left lung resection, and I'm currently on a clinical trial. I take it every 12 hours, so twice a day, at the exact same time. I have to give them a pill diary. It's pretty much a medication that targets people with a genetic mutation that's called a TRK mutation, and it basically is supposed to, keep you comfortable or suppress the cancer until a cure is found. My experience, it's been good. I've been on it since 2018 of July, so I'm going on 6 years if I'm doing the math right. Pretty much, my quality of life has increased tremendously. I'm not in as much pain as I used to be. I do have symptoms of like withdrawal when you miss the medication or when you get close to the medication being due. But other than that, like my quality of life has increased. I'm more active now. I'm doing more things. The only thing I would say about the clinical trial is like it is pretty much it controls your life a little bit because you gotta have the medication on you at all times, and it also has like certain side effects. Like if you want a family in the future, that kind of puts a dud in it. What I would say is ask questions before you start, and I would say pre-plan. Like I was blessed to have the option to freeze my eggs before. So I was able to freeze my eggs before I started the clinical trial. I will also say do your research on the side effects because the side effects, they do kind of hinder your life. It gets kind of painful when you do miss the dose. But for the most part, the pros definitely outweigh the cons.
Let's talk about how to identify patients who may benefit from tumor agnostic therapy. Let's pick Dr. Lopez Riaz's brain on this. So, Dr. Lopez Riaz, so who should be tested and when they should be tested and how they should be tested for these tumor agnostic therapies?
Okay, so I'll start by trying to answer the last two questions. I am a huge advocate of reflex testing, which means you consensuate with your clinical team, with your clinical tumor board, who should be tested, and then you don't wait for a requisition form. You initiate the testing workflow, and that saves a lot of time and a lot of troubles down the line because the results are probably going to be ready faster. So I think this should be implemented whenever possible. And then, with the exception of microsatellite instability, where we can still use immunohistochemistry as a screening method, probably the best way to identify these patients is by doing next generation sequencing. We can discuss how big should the panel be, but it's the best way to make sure that we don't miss any of these patients. So really, as I said at the beginning, having this tumor agnostic perspective in mind really helps more and more patients benefit from comprehensive genomic profiling results. And finally, who should we test? Of course, we would all like to have all patients with advanced or even early stage solid tumors receive comprehensive genomic profiling, but it's probably not realistic, not sensible in some regions, in many hospitals. So I think it's good to have a strategy, and that's why I think we need to use all the information we have to increase the likelihood of finding patients that can benefit most. So we now know which are the subtypes that have a higher frequency of microsatellite instability, for example, or as I said earlier, we also know that the likelihood of finding an NTRK fusion is much higher in certain molecular subtypes. And I think the same holds true for BRAF mutations or RET alterations. So what I'm trying to say is that try to use all the information you have to make sure that you don't miss any of these patients.
Thank you so much. Let me ask Dr. Simbaredu on her thoughts on this question.
In my opinion, all patients with cancer should be tested, and they should be tested at the time of diagnosis and every time a treatment decision is to be made. The molecular profiling should become an essential component of the diagnostic workup and should be covered by patient's insurance. And the ideal workup should include next generation sequencing, all the immune markers, including PD-L1, MSI status, and tumor mutational burden, as well as all the markers for which tumor agnostic treatments, as discussed today, are available.
Thank you so much. I personally agree with both the perspectives, and my personal pitch, hopefully in the future, should be genomics should be a part of diagnosis for every patient with cancer. Again, let's talk to let me ask Dr. Simberedu this question. So, how can treatment outcomes be affected by the availability and use of these tissue agnostic drugs?
It can be affected significantly. Since the approval of the drugs that we discussed today, many patients had the benefit of these approvals, and some of these patients are now cured. So, the availability of tumor agnostic drugs, and of course, to use them, you have to have the molecular profile first and the molecular alterations and the PD-L1 status and so forth. So, if patients have this data available, and there are, as mentioned, as discussed today, many drugs that are available. But also there are many clinical trials to which these molecular alterations can be matched and the patients can have the benefit of these approvals. In our clinic, we have many patients who had the benefit of targeted therapy against the patient's tumor molecular alterations, and some of these patients are now cured.
Thank you so much. Dr. Lopez Rios, please, your thoughts on this question. How can treatment outcomes be affected by the availability and use of tissue agnostic drugs?
Yeah, completely agree. But at the same time, I think we need to make sure that this is not an excuse for not testing. So I think we need to probably make sure that the results are out there. So it will strengthen the case for faster approvals. That's why I'm also very fond of course, clinical trials and academic research, because I think it's helping the approval of many of these drugs and also biomarker testing tremendously.
Fantastic. Thank you so much. So let me turn to Dr. Simberedu. So, what are your final thoughts here on the future of precision oncology?
It is very encouraging that since we started the first study across tumor types, the so-called IMPACT trial in the phase 1 department at MD Anderson, the Initiative for Molecular Profiling and Advanced Cancer Therapy, the FDA now has approved over 160 drugs that are considered targeted therapy for patients with cancer or leukemias. In my opinion, in the future, we will be able to use artificial intelligence and machine learning techniques to better understand in depth basis molecular profiling, the tumor biology alterations that cause the cancer, and this will be used across various areas of precision oncology, from diagnosis to regarding pathology. Imaging is a basic component of this. Diagnostic imaging, tumor biopsies, and profiling, and then to better try to understand who are the patients who respond to these treatments, and how we can design the next level of trials where we will be using all these techniques and this data to inform the optimal personalized treatment for every patient with cancer.
Fantastic. Thank you so much. Dr. Lopez Rios, please, what are your thoughts on the future of precision oncology?
So here I'm going to focus on communication. I think now that for me the biggest challenge is how to integrate so much information coming from many different sources and with so many people involved in patient care, including of course patients and stakeholders. So I think for me now the future looks very promising, but we need to find better ways of communicating effectively within the teams that are taking care of all these patients.
Thank you so much. I completely agree with both Dr. Leah Simberedu and Dr. Lopez Rios. So, tumor agnostic precision oncology represents a promising shift in the cancer treatment paradigms, emphasizing genetic alterations over traditional tumor site based classifications. However, we have big challenges in our front. What are they? Including the identification of number one, reliable biomarkers, the design of appropriate clinical trials, the execution of these clinical trials and in real time so that patients in the real world can get access to these therapies, integration of this into existing healthcare systems while addressing ethical and societal implications. But here we are, and I see the tumor agnostic precision oncology is a major paradigm shift in cancer treatments, and we are really hopeful for the future of personalized medicine. Thank you so much, Dr. Simberidu, and thank you so much, Dr. Lopez Rios. Thank you for this great discussion for this very important topic in personalized oncology area. Thank you.
It was a pleasure. Thanks a lot.
Thank you very much.
Thank you to all the audience, and thank you for participating in this activity. Please continue to answer the questions that follow, and please do complete the evaluation. Thank you so much.
This program was presented by Medscape Education Global.